This section of your class material is found under Nutrition, Metabolic Pattern, and we are going to discuss the condition of colic, a very common concern that parents see their pediatrician for, or their family doctor, or maybe go to a clinic setting for ambulatory care. We would see it in conjunction with maybe other conditions if they were in the hospital, but typically you would not expect this to be an admission reason when we look at colic. So exactly what is it and what are some of the symptoms that you might see in this condition? The infant is very unhappy. He's crying very loudly, and usually it's for at least 3 hours at a time. And there may be pinpoint times in the day or their schedule that this occurs. Frequently it is late afternoon or evening when the schedule of the family is usually the most hectic. We will see this baby pull their legs up to their abdomen, bending the knee, and then kicking their legs out and crying, and nothing really seems to make it any better. It's usually in an infant that's less than 3 months of age. Again, that's the most frequent occurring time. And we would be looking at how their feeding is like. Are they tolerating the formula that they're on, or breast milk, and are they gaining weight? So even though the parent brings this to attention of their crying and fussiness, we would want to do a complete assessment of their GI functioning and take a good history in regards to it, because they could be having these symptoms for other reasons that it is common to see. Some of the causes that we find in literature as to what makes this happen and why the baby is so uncomfortable, sometimes it's because they are taking the feeding or the formula or the breast milk too rapidly, and their tummy just can't tolerate that amount of fluid within the GI system. It can be seen when we take that history that they are an overeater, that they're being fed very frequently, and sometimes we see this with the breastfeeding babies because they're feeding, maybe every 2 hours, and so the parent is a little distraught with that frequency of feeding, and sometimes that stress then can be reflected in the baby himself. You do want to assess what is the fit between this infant and caregiver, what seems to be the emotional characteristics of the parent. Are they able to soothe the baby or comfort the baby, and what have they seemed to be doing as you're observing and talking, with the parent about the situation. Of course, you want to ask a broad open question. Tell me about your feeding schedule, or is there anything else that's going on during that time? Show me how you hold the bottle. How are you burping? Is there a history of allergies in the family? Is there any smoking in the environment? Even if the person goes outside to smoke, that lingers on their clothing, and it can be a cause for an uncomfortableness for the baby and trigger a colic situation. So you never want to assume it's one thing, but often the picture is painted very clearly from the parent about what direction you should take. So to actually determine that it's colic, you'd be ruling out other things or other conditions, and that's going to be done by your physical assessment and the history and the questions that you ask. Has there been any trial of other formulas? And that's often a pretty easy thing to give to the parent in their little toolkit of what to do. And often the parent is so frustrated and tired that they are grasping at anything that you might tell them to do to make the situation better. So offering them some things they could try for a period of time and see if the symptoms, decrease or not. So trying a different formula, maybe a soy formula, for example. Then assess the baby and the family and their interactions. Does it seem to be a family that's, kind of on edge or high-strung, or, do they seem to be laid back, or how would you describe the family situation, and then knowing what's occurring at the most typical time when colic occurs, around the mealtime. They're trying to get a meal together. Is one of the parents coming in from work, or both at the same time, and other children in the household? So that's one thing that we would talk to them about how to make that a quieter time, or how things could be rescheduled to make that feeding a little bit less stimulating for the baby. The formula change, and those things aren't going to happen immediately. It may take a couple of weeks. If it is truly a formula issue, then they've got to get all of that formula out of their system and all of the irritation that might be in the stomach or intestines. So, we want to make sure the family understands there's no one magic, bullet that's going to fix it immediately for them. And, we're in a society where we want things very quickly, and we want an answer, and we want our life to go on as seamless as possible. There are medications that can be used, but they're not research proven to completely remove the colic problem, but Atarax, chlorohydrate, or Malacon drops can be used. Usually there's no harm in providing a prescription for those from the physician, and it does seem to calm the baby, relax the baby, and the parent having something to do about it often decreases their stress as well. You want to talk to them about no secondhand smoke, even on the clothing. And then we can demonstrate what's called a colic carry. And there's a picture in your book of that where you place the baby almost like in a football hold, but over the arm, and you're applying some pressure there through the arm itself in that position. And sometimes that's helpful, and it's similar to this. And you can see in that expression that baby is really fussy and he's trying to kick that leg up, but sometimes just causing some pressure externally, by them positioning on their own weight, on the arm seems to give some relief. Other things that might help are swaddling or tight wrapping the baby. The rhythmic sound of vacuuming. Some parents will say, well, he stops this when we put him in the car seat and go for a ride. So you try to determine what things have or seem to make it a little bit better, and then, plan that intervention plan for the family. So just to recap, it's a common situation that parents call in and ask for assistance with, and being very thorough in your assessment and histories, and then giving them some tools that help them feel like they're managing it. It may last for a month or so, but you want to make sure you've ruled out other or assisted in collecting information that would help rule out, any other medical problems. Now, under this same topic or unit, nutrition metabolic pattern, we're going to look next to lactose intolerance. And then you have to really remember that this is on a continuum. So every baby, every person, and of course even adults may have lactose intolerance, but it'll be at different levels. So it's highly individualized as to how severe the situation might be. When we're looking at children or the pediatric population, there are 3 different types of lactose intolerance. The first one is congenital lactase deficiency, and this one, the timing, it occurs soon after birth or after taking a lactose-containing milk, human or formula, and if this is identified in this early age, then it's usually congenital, and it will be a lifelong diet of restriction of lactose in the diet. And this is rare, it's not as common, but it would be a lifelong vigilance with the diet. The late onset lactase deficiency, or primary lactase deficiency it may be called, is the most common one, and it manifests from 3 to 7 years of age. And then lastly, we might see a secondary lactase deficiency when there has been damage to the intestinal lining, such as following rotavirus. So anything that would disrupt, the normal bacteria, flora that should be in the intestines, being on an antibiotic for a long period of time, all of these can negatively affect absorption and functioning of the GI tract. Some of the symptoms: abdominal pain, cramping, bloating, excess flatus or being flatulent, diarrhea 30 minutes after consumption of a food item that has lactose in it. Some people already have eliminated what they know makes it worse, and they can manage their diet and nutritional intake by just staying away from a few items. Remember one student who said that it was Dairy Queen soft serve ice cream for her, but every now and then she just had to have that fix, and so she knew within 30 minutes she needed to be close to a bathroom. So our history, what is the nurse's role with this condition? Asking the right questions: when did it start? How long has it happened? What are the symptoms? What changes have you made? Have you noticed any improvement with those changes? Is there a history of lactose intolerance, in another family member? And if they have reduced food items that have lactose in them, have they noted an improvement? Now, again, it's not a quick fix with that diet change. If there has been, a lot of irritation to the intestines, it's not going to be an overnight being well and there not be that pattern of, a lower abdominal cramping. It may take a month or so to see that improvement. So asking the parent to keep a diary of the food intake. There's another test that can be done called the breath hydrogen test. Lactose intolerant patients will have a higher level of hydrogen in the breath that they, blow out. So 20, the level 20, or more above the baseline is considered positive. Then another test that could be done would be direct endoscopic visualization. So, a little bit more invasive as we move through these different diagnostic testing and fluid sampling. Most cases are diagnosed just by altering the diet and keeping the diary, and this is referred to as an elimination diet, in which you eliminate the offensive food item, and then you note if there's improvement over time. But remember that time factor, it's not overnight. So you got to explain that to the parents so they're not frustrated. So the elimination diet, knowing what that means, a soy-based formula is tolerated better. They may need calcium and vitamin D supplements if they are on the soy-based formula. The use of yogurt is controversial. If there is the need to replace the bacteria flora, pasteurized yogurt will have the lactase enzyme deactivated in that process of pasteurization. So the homemade fresh yogurt is tolerated better. It has acidophilus in it, or even an over-the-counter acidophilus might be needed. Then a lot of teaching, and assessing what the family's knowledge level is and their ability to keep, up with the, diary of the diet, we would like for the baby or that young child to eventually be able to drink some milk. So we might do kind of a trial period where we give them a little bit of milk and see if the symptoms are too severe, or how much do they tolerate. But a really important point is that you give that milk with other foods. They wouldn't just be given a glass of milk to drink. It might be a small amount of milk on cereal, for example. And it should be a cereal that is low in sugar, because that sugar can alter the bacteria flora as well. They could possibly take an oral tablet, such as Lactate, and for some patients that helps. Or for some, just changing, to Silk or a lactose-free milk product. They do need to look at eating very small amounts of dairy foods daily, just to keep that bacteria that needs to be there adapted and changed with their diet. So, going back to our last slide to conclude about lactose intolerance, with the word intolerance, that means usually they can have a little bit of milk or some milk product or cheese product. So again, it's finding out what the happy medium is for that child. And of course, you want to be monitoring their height and weight and just making sure that they are growing as they need to. So those are some things that you would want to consider as a nurse. So communication skills, assessments, and teaching, of course, are all very important. Then I want to say just very little about these two topics that are under the nutritional metabolic pattern, Kwashiorkor and marasmus. And when we look at these, we typically think of children in under economic countries, and it's sometimes referred to as the Kwashiorkor as being the sickness of the older child when the next baby's born, because the only food item for that newborn is mom's breast milk. So the older child would have been breastfed until the second one comes along. And then that older child has lost, he may be, 2 years old or so, and he's lost that source of protein. So what we see is the malnutrition. And these are all often exhibited on the drives to raise money for, third world countries. And you often see a child portrayed who's between 1 to 4 years of age. Their extremities are very, very thin. They have what we refer to as wasted buttocks and extremities, meaning they've used all their fat stores. But their abdomen is very prominent, their skin is scaly and dry, and they may have even lost some pigmentation in areas. They now may develop blindness, and they'll have lowered resistance to any other pathogens or bacteria. Frequently they'll have diarrhea, and it's almost always in a geographic area of need. Occasionally you'll see in reports of a child or an infant who's not been fed properly, has been abused, and may also exhibit these same symptoms. You want to rule out in the United States, for example, why is this child having diarrhea? Why is the skin affected? Why is their abdomen enlarged? Could there be a malabsorption reason for these symptoms that we see? So you always keep your mind open as to what might be the cause as you're collecting data and completing assessments in a history. Now, marasmus is not related to, the third world country or a specific geographical area. It's just a general malnutrition and usually a delayed growth and development. And sometimes we would see this in homes where children might be in like an orphanage type home and they've not been given adequate nutrition or even stimulation as they need for growth and development. Or again, in an abuse and neglect situation, we may see it. So the treatment, of course, is to replace their diet with high quality proteins, to increase their carbohydrates and their vitamins and minerals, and then rehydrate them, antibiotics if needed for secondary infections, and teaching about growth and development and stimulation of the baby or young child. So looking at the whole situation and not just the gut and the diet per se. The next condition that we'll talk about is referred to as failure to thrive, or FTT. A lot of times we'll see an admitting diagnosis of failure to thrive, and then what is determined during that hospitalization is what was the cause. Now, failure to thrive means that the baby has not progressed physically, maybe even emotionally and mentally, and that we may even see some physiological alterations due to that. They may be delayed, with their growth and development. So we have to determine, is there an organic reason why they're not growing as they should? And we're doing heights and weights and BMIs on these kids. So any baby who's fallen below the 5th percentile is of great concern to us on a growth chart. So we would look at that. So by definition, we would be seeing with failure to thrive inadequate growth resulting from inability to obtain or use calories required for growth. So, they may not be being fed correctly, or they're not tolerating it, they're having increased diarrhea, or the parent, and maybe a feeding issue. The parents did not understand correctly how to mix the powder and the powdered formula, and so they diluted it for that reason, or perhaps even to make it last longer because of financial concerns. So we're always plotting infants, toddlers, preschoolers, and school age and adolescents to see what they're trending on a growth chart. It's very important that when you do a height and weight and then a BMI, that you compare that child to themselves. What were they the last time? Are they trending downward, or was it just one dip and now they're back up again? So you look at how that individual child is progressing and how you might plot them on the growth chart. when we classify or look at the different types of failure to thrive, there are three general categories. One is the organic, or OSTT. That is used typically when there's a physical cause. Say they have congenital heart defect and it's hard for them to have the oxygen level they need to engage in a feeding activity. So they tire very easily when they're sucking, and they don't take in the amount of calories that they need to take in. So we can see these same symptoms of failure to thrive as one of our, jumping off points at looking at congenital heart defects. Then there's non-organic, or NFTT, in which, as it says, it's not related to a disease, but psychosocial factors. And that would be the neglect area that we would be talking about. And then, the infant that doesn't fall in either one of those then is referred to as having idiopathic failure to thrive. So some of the symptoms, what would we anticipate seeing if there was a failure to thrive baby being admitted, or they've called in and said, we're going to admit this baby? We certainly want to do a height and weight, BMI, and use the chart forms that are by percentage by age to see if they're below that 5th percentile. Then assess them thoroughly for their gross motor, fine motor skills. Do we see any delays there? Then how alert is the baby? Is he lethargic, or does he have a shrill cry? Does he tire out when feeding? That would be like dyspnea and exertion. You give him a bath and he becomes, really non-responsive in his motor movements. What is the hygiene like? Has he been taken care of, or looks like he has? And then sometimes what we see too is what's referred to as a wide-eyed look about the baby, and it's also referred to as radar gaze. And they appear to have very ominous eyes because they lack the subcutaneous tissue around the eye, so the eye is very prominent. Again, behaviors, are they unresponsive, or are they real stiff when you hold them? A child with CP, for example, or a neurological issue may not be able to eat and swallow and keep, food and calories in that they need. And then when you hold the baby, are they a non-cuddler? Again, that could be a CP baby. Or is there any fear or no fear of strangers? Could this really be, abusive and neglectful situation? Sometimes we see the doctor requesting for the nurse to feed the baby and see what differences there are. And one has to be very careful when fulfilling that particular order, because we don't want to offend the parent. We don't want to just jump off and say, the doctor wants me to try this to see if you're doing it wrong. That would be very non-therapeutic. So it does require some finesse. Just let me see how he does. I want to hold him and just see what happens. So you try to make it as non-threatening as you can. If they are feeding, you try to make an excuse to be in the room, or even to say, well, let me just see how he does for you. Is this what you were talking about? Or I see he's doing this. Is this what you meant by that? So you validate, information. And then our treatment. We want to make the feeding situation as unstimulating, or, a more quiet environment. So we're ruling out environmental problems. To have a calm, even temperament with the baby. To have consistency with the feeding. And we're trying to foster that growth and development. So this should be a social event so that there's eye contact when feeding. And then, you know, we want to teach by example. So if we feed the baby, hold him a certain way, burp a certain way, then, you know, perhaps the parent will pick up this so you can role model. If it is truly a neglectful situation, it needs to be referred to social services, and the nurses have liable if they do not, you know, report this with this type of data. Then we want to see where they are developmentally. You know, what fine motor, gross motor skills do they have? So when we think about failure to thrive, that can be a really large umbrella of conditions. It can be an organic problem, such as congenital heart, to being abusive or a lack of knowledge by the parent. So we go in with an open mind, trying to collect and verify data, and some of those findings in regards to holding the baby yourself can be very helpful. Then if it was a feeding issue, we want to teach and support and correct that for sure. And if it's a malabsorption reason or a disease process reason, then that treatment plan for that diagnosis would be enacted. If it's a true neglect, then a referral. And again, you know, we want to support the parent in remembering our professional role, you know, for that entire family, but maintaining the safety for the baby or the young child. The next category of conditions under this nutrition metabolic pattern we'll look at is also referred to as inborn error of metabolism, meaning that something that is needed for metabolism is not there, or there's a deficiency of it. Could be an enzyme, for example, or a hormone, for example. They're born in with the situation, so therefore it's referred to as being congenital. So the first condition that we'll talk about that's in that category is congenital hypothyroidism. So we'll be looking at these conditions of congenital hypothyroidism, and I'd like for you just to search quickly on YouTube and see what type of video you're able to acquire on this topic, just as an additional research for you. What we see in this condition is that there's a decreased amount of the thyroid hormone, and because it may vary from infant to infant, the symptoms will vary as well. When they occur as early at birth, then it's usually a more severe case. And frequently they'll have other congenital anomalies, so that is of concern to complete, you know, that assessment, you know, of their entire body. It's seen more frequently in Down syndrome and more frequently in the preterm because that hormone has not been developed enough and being circulated. And usually that with the preterm will resolve as the baby matures in age and the function of its systems, you know, increases. So diagnostically, we know that screenings can be conducted with the neonate, and that's usually within 2 to 5 days of the birth, and usually at least between 24 to 48 hours of age. It's a blood spot test. The thyroxine T4 is measured. All states do this test on newborns, and the value level that is considered low is less than 6 micrograms per deciliter. Some of the symptoms that we can see with congenital hypothyroidism are all a deficit. So there's dry skin, puffiness around the eyes, sparse hair, constipation, very lethargic or sleepy, and over time there would be a mental decline. Early detection is just paramount, and that's why every state screens, on babies. Prompt treatment is needed for brain growth in that infant. The brain develops about 75% of its size, of adult size, by the end of the first year. So any time lost during that infant period can have really bad, effects. One thing that we want to watch is, do the symptoms decline once treatment starts, and that's, a replacement therapy for them. It'll be a lifelong therapy, and it's oral thyroid hormone, and it would be crushed. It comes in pill form and then added to the formula, water, or food. But it should not be added to the whole bottle or to a whole serving of cereal, but only in just, a small amount, like a half a teaspoon, for example. If a dose is missed, parents will want to know, what do I do? You double up on the next dose the next day, give 2 times that dose. Following testing of medical symptoms of congenital hypothyroidism is necessary to follow the results of that and any changes, and monitoring does the medication dosage help, and also doing bone testing for ages. Are their bones growing as they should? So that would be another supportive test that would tell us that things were working. Then you would want to teach the parents about, overdosing and what symptoms might be present if that dosage is too much. The pulse is very rapid. There's dyspnea, irritability, insomnia, fever, sweating, and weight loss. So if they've overdosed, things have gone too far that direction. If there's been inadequate treatment, if that dosage is not sufficient, we would see lethargy or fatigue, sleepiness, decreased appetite, and constipation. So those are all things that the mom should make some notation in, or dad, in their diary regarding treatment, and that's shared with the physician. So congenital hypothyroidism, assessments, totally lifelong treatment, and making sure the parent knows what to do if they missed a dose, and then what are symptoms if they've overtreated or undertreated, and why it's so important, that all states, do test. The next condition is called Phenylketonuria, or PKU. It's abbreviated PKU. So it is also an inborn error of metabolism, so the baby lacks a particular enzyme or doesn't have it in sufficient amounts. In your study packet, you have a handout to complete on PKU, a study sheet. So be sure and complete your answers on that. It's autosomal recessively inherited. It's a disorder of amino acid metabolism. And when we say it's autosomal recessive, that means that 2 carriers, or 2 people who carry this alteration would have, with every pregnancy, a 25% chance of having a child with PKU, a 25% chance of the child being normal in regards to PKU, and then a 50% chance with every pregnancy of being a carrier. Now, another word that we use for carrier is heterozygous. If you're heterozygous, you're a carrier. If you're homozygous, you actually have that disease and the symptoms. What we see is that the body does not break down phenylalanine and cannot use the phenylalanine or that protein because it lacks an enzyme. There's about 1% in 25,000 births, according to the March of Dimes, and that has pretty much remained stable as in numbers. The autosomal recessive pedigree, the patterning there that we see is just what I mentioned. If two carriers marry, these are their options if they're heterozygous, which is noted by the half-shaded colored area. So they have a chance of having a child who is, with every pregnancy, being a carrier, being non-affected, and then having the disorder, completely having that. So you need to know those odds, and if the parent reported to you, this is what I understand, you would need to know that they had correct information or not. So just some more information on autosomal recessive. We're looking at both parents are carriers or heterozygous, and that means they don't have the disease, but they carry that, and there's a possibility that those symptoms would be then noted in their offspring. So a 25% chance, or 1 in 4 with every pregnancy, to have a child with the disease, a 25% chance with every pregnancy to have a normal child, and then a 50% chance with every pregnancy of producing a child who is termed as being a carrier or heterozygous. So when we look at this distribution, this is not a condition that's affected more in males or more in females. You know, that is equal. That's not a determining factor. Some other conditions that are transmitted the same way would be cystic fibrosis, Galactosemia, sickle cell anemia, Tay-Sachs, maple syrup urine sugar disease. So there are other conditions, but this is going to be one of the more common ones. So with PKU, I said there's a deficiency. That's why it's called an inborn error of metabolism. There's a deficiency of a liver enzyme. And the name of that enzyme is phenylalanine hydroxylase. Now, the purpose of phenylalanine hydroxylase is to break down or take action on phenylalanine. And phenylalanine is an essential amino acid, and it should break it down into tyrosine. But the body cannot do these steps because it lacks the enzyme. So therefore, phenylalanine accumulates and causes damage to that infant that can be permanent and lifelong. Now, in a baby who has not been treated for whatever reason, and they have increased amount of phenylalanine in their blood, what the symptoms might be is a musty, mousy, barnyard type of odor, a very offensive odor. That phenylalanine is leaking through the skin itself. Behavior-wise, they're very irritable, seizure activity, and if continued to be untreated, they're going to be mentally retarded and have schizophrenic-like behavior. They usually have an extensive rash and very fair skin, even if the parents are dark-skinned. And the reason for that is that phenylalanine is needed to make melanin, which is, attributes to the coloring of the skin. Now, screening is required by all states that the infants are screened or the newborn is screened. Not any sooner than 48 hours because things just aren't working right to that point as the baby's making transitions. Because now that we're seeing earlier and earlier discharges, that becomes a problem because even when we do that screening, it may not be accurate. Because the baby needs to have been taking formula or breast milk for a day or so to kind of just see if they lack the enzyme or not to break it down. If the screening came back positive, it's very important that that should be repeated in 1 to 2 weeks of life. The value that's of concern is a value greater than 15 milligrams per deciliter, and that's considered dangerous. We try to monitor and keep them between ranges of 2 to 6. So that means, it's a lifelong vigilance of measuring and keeping a diary and doing blood work. The diet for PKU is very strict. There are formulas that have modified proteins that their body can handle, that they don't need the phenylalanine hydroxylase. Some of those formulas, names of them are Phenylketonuria, Menethine, and Albumase CP. The child needs enough protein, for growth, and, infancy is a peak growth period. So it makes management pretty difficult because almost every food item, as we progress from the formulas, almost every food item has some amount of phenylalanine in it, being an essential, amino acid. So we have to consider diet for life. So a lot of supportive care and teaching and explanations and reading of labels and screening times and, maintaining the rigid diet, promoting compliance and return visits. And the diet for life is considered evidence-based practice by Rezvani in 2007. But what you may see is that some physicians will say around age 7 or 8, let's add a little bit more phenylalanine to the diet and just see if their body can handle that or not. Then the other school of thought is if they have a deficiency of that enzyme, phenylalanine hydroxylase, we should never overtax their system. They should be on the diet for life. So you'll see the parents reading about different conditions in which, PKU is treated where they can try out other things. So the diet for life, knowing when screening occurs, why the test is repeated, in about a week when they've had enough formula on board to kind of test their system. What are the names of formulas that can be used? Why the diet for life is considered. What are symptoms if they're untreated? And then the big question is, how do we make sure this child has normalcy in their life? How do you deal with, a birthday party with the food items there? How do you deal with, pizza parties and that type of thing? So the diet is pretty restricted, but the how one approaches it within the family, a very positive way, it can be dealt with, very positively, and outcomes excellent. Another inborn error metabolism that is autosomal recessive is galactosemia. Now, this is not lactose intolerant, but galactosemia. It's a disorder of the carbohydrate metabolism. About 1 in 50,000 have this according to the March of Dimes. This condition is a deficiency of the liver enzyme galactose-1 phosphate uridyl transferase. So a very long name for that enzyme. So they have a deficiency or a lack of the enzyme, and as they take in formula that has galactose in it, we can see very early symptoms of failure to thrive, poor sight, behavioral changes. There can be cataracts of the eyes, and permanent kidney and liver damage, enlarged liver, can affect the brain and cause mental retardation. So the importance of early screening and then definitive testing and then diet are, mandatory. It can cause mental retardation, jaundice, ascites, down through seizures and coma. And if untreated, they would die, in a month or less. Signs and symptoms, are on the other screen that we've looked at, and the Martyrdams advocate screening at birth, and it can be done in that battery of tests, like with PKU. And so then a physical exam to see if any of the conditions that are brought on by galactosemia occur. So they would be testing for galactose, and it would be abnormally high, circulating and causing damage because it lacks the enzyme to break galactose down. So that's why you have it free-flowing in the blood versus the suffix emia. The treatment is lactose or galactose-free formula. That could be Nutritional or a soy-based formula. And the same two theories, diet for life, try something out around age 7, but would need continued monitoring. This diet is not as restrictive as PKU, but it does require a lot of label reading. So no dairy products, no prepared foods that come in boxes like hamburger helper or pancake mixes or gravy mixes. Nothing in that aisle could be utilized. It's also used a lot as a stabilizer in foods. It's used in penicillin. It's used in all candy and chewing gum, and it's in most breads. So even though the diet is not as restrictive, it does require a lot of support for the family unit. And they may need to be on calcium as a supplement. This slide is just depicting all the different body areas that can be affected by galactosemia, the brain damage, the cataracts, jaundice, enlarged liver, kidney failure, so, a total wipeout of everything and even death, within a few weeks if not treated. Ideally, a person with galactosemia should have a blood galactose 1P level below 3 to 4 milligrams. So you want to try to maintain it at that level. The restricted diet, we don't really want them, below 1 because then they're not getting the proteins they need for growth. There is an organization that I've listed here that for further information, or if you have a family that would need to be referred. So we've looked at several conditions now, congenital hypothyroidism, we've looked at failure to thrive, marasmus, Kwashiorkor, to inborn errors of metabolism, and autosomal recessive inheritance. So, how we teach families, what we would expect is improvements if our interventions work, types of formulas that might be used, and remember that concern over normalcy, and how significant that is for their growth and blossoming here. One of the hydrangeas from my yard. So think about, that child and infant being someone we want to blossom and have full potential. The last section that we have here will be on diabetes, and I think we'll have time to touch base on this in class. So I'm not going to record a lecture on it at this point. I may, if I see we run out of time later, that it will be on, the same set of PowerPoints. So I will be anxious to hear from you and answer questions that you might have and to review the content that we've presented today in class for you as well.